Okay, I guess I can start now. Thank you for the very kind invitation. It's lovely to speak to you. It's a shame I can't be with you. I hope you have a translator because I will be speaking in English. So I'm going to talk about ITP, the disease, the strange disease, and look at the old treatments and then show you or try to persuade you that the TPO receptor agonists are superior to the older therapies, especially during a pandemic like the COVID-19 pandemic. So these are my disclosures. So ITP, we know ITP is autoimmune, but it's not. We don't really understand the disease terribly well. Sorry, someone's speaking in the background. Is that for me? Are you speaking to me? No. It's an autoimmune disease, not terribly well understood, and there are lots of different cells and molecules involved, and ITP is a whole collection of different diseases that look the same. But that doesn't really matter in a way, but it's a fairly benign disease. It's not like the last talk. It's not acute myeloid leukemia. Not many people die from ITP. And most patients either respond to a therapy or many patients need no treatment at all. But sometimes our first line therapy fails and we have to decide what to do next. And until the TPO receptor agonists were developed, the older therapies are they're not very good. We know that immune suppression can be useful in autoimmune disease. We know that because we've used these drugs for a long time. They decrease inflammation. They make the patients recover in a sense, but the responses are not consistent. And we don't often achieve remissions. And if you look at non-obese diabetic mice and you completely ablate their immune system if they have an autoimmune disease, many of them still relapse. So these are complex diseases to treat. So let me look at our commonly used treatments: corticosteroids, IVIG, immunosuppression, and splenectomy, just briefly. We've used steroids since the 1950s. We've used them in many branches of medicine. They are great anti-inflammatory drugs. They diminish phagocyte destruction of platelets. They lower the antibody levels against platelets. And their effects start to work in about 1 day. But long term, they don't actually affect the natural history of ITP at all. They have many side effects, and they're associated with a poor quality of life. We know that from the iWish study carried out by Novartis, and they're very unpopular with patients. Now, we've looked at data from pregnancy and also the COVID-19 pandemic. During the pandemic, for people who are COVID-19 positive with ITP, we've been using a small dose of steroid, 20 milligrams a day, and many of them will respond. In pregnancy, again, we use small doses of steroid, 20 milligrams a day, and many of them respond. So should we be reducing the dose of steroids in all ITP patients? Should we stop using 1 milligram per kilogram? Maybe we could use 20 milligrams of prednisolone or prednisone per day, and then if there's no response, increase the dose. But if they do respond, then simply give them a short course of steroid at low dose. And a number of us are looking at this now, and it seems for the patients it's much better, fewer side effects. IVIG, of course, we've used since the 1980s, and the response time is like steroids, maybe slightly quicker, but it takes a long time to give IVIG. It's very expensive, and you don't get any lasting remissions. Headaches are common, and there are other side effects as well. But we do use IVIG, especially in pregnancy and sometimes as a rescue, but it's not a good long-term strategy. Now, immunosuppression has been the backbone of ITP management, systemic lupus, rheumatoid, many autoimmune diseases. But these drugs have got many side effects. And often, if you look at the table below, you'll see lots of side effects there. I don't want to go through the side effects. But quite often the side effects are so bad that they outweigh any benefits to the patients. So they feel bad on these drugs, and there are very few lasting responses. So looking at the older method of managing ITP with our goals, which are still not very clear, what are we trying to achieve with ITP? How many of your patients do you think actually feel better with your immune suppression? How many patients do you think feel worse with immune suppression? And how often have we changed the natural history of the ITP using the old drugs? Not very often. And how many patients have died because of immune suppression? So we're in a pandemic now, as you know, 1.5 years in a pandemic. COVID-19 is a serious infection for many patients. Immunosuppression, therefore, is not really ideal therapy for any disease and for ITP. But the more recent treatments like the TPO receptor agonists, I would say, are better therapies because they do not suppress the immune system and they have incredibly high efficacy, unlike the old drugs which do not have high efficacy. So if a patient fails to respond to first-line therapy or relapses after a course of first-line therapy, we need to reassess the diagnosis. Are we sure this is really ITP? Could it be something else? And this is difficult for a disease like ITP because it remains a diagnosis of exclusion, as you know. So you can never be 100% sure that you're dealing with primary immune thrombocytopenia. Often nowadays we watch and wait. There's no panic with ITP. This is not leukemia. Not many people die of ITP, so usually we can relax and watch for a while. But maybe they do need treatment. You have to give something. So what are the options? And remember, the treatment, the old treatment, may be worse than the disease, and that is the problem. This paper was published in 2001. It's an old paper, but that doesn't matter. This group looked at the deaths in their ITP cohort. Were they dying of ITP? Was it bleeding, or was it something else? And 50% of the deaths were caused by infection, which was brought about because of the immunosuppression. So benign disease does not kill you. You have treatment, which then gives you infection, and then you die. So this is not great. So in the international consensus report published in Blood Advances, you can see the reference at the bottom, hopefully, we had a box called less robust evidence. These are drugs where there's no good trial evidence. And this includes all the steroids, splenectomy, chemotherapy drugs, danazol, which is an androgen, rituximab, etc. And then bear in mind that these drugs really have not undergone any kind of clinical trials. So we put them here, although rituximab is above in the robust evidence box because we have so much data on rituximab. But you see the less robust group is azathioprine, danazol, dapsone, cyclosporin, etc. These are drugs which we used for a long time when there was nothing better. This is all we had. and we had to use them, but the evidence base is weak. But now, really, over the last several years, we've moved into an evidence-based approach. We have drugs now fully approved for ITP. Eltrombopag, romiplostim, the first TPO receptor agonist we approved for ITP. Fostamatinib, much more recently, a SYK inhibitor. Avatrombopag, a new TPO receptor agonist. Now, on the right, if you can see, there are drugs in development which will be available, I guess, in the next few years, like the anti-neonatal FC receptor drugs, the Bruton tyrosine kinase inhibitors, anti-complement, and other drugs. But these are not approved, they're still in the trial phase. So in the consensus, we outlined a group of drugs where there is good trial data, usually double-blind, placebo-controlled, and these are the drugs. And it's mainly the TPO receptor agonists, eltrombopag, romiplostim, and the new drug avatrombopag. We also have fostamatinib there, which is a SYK inhibitor, and rituximab. Now, the TPO receptor agonists have changed ITP management dramatically. It's very different today than it was, say, 10 years ago, managing ITP. The reason they have changed management is because the response is almost 100% to these drugs, which is remarkable. They work within a week. They have very few side effects. They have a sustained duration of action. When they work, they keep working. The quality of life for patients taking a TPO receptor agonist is very much better than with azathioprine, mycophenolate, cyclosporin, etc. And we have more than 10 years experience using these new drugs. And worldwide, I know the Dominican Republic may not have all of these, but worldwide, we have 3 TPO receptor agonists. We have eltrombopag, an oral agent taken once daily. We have romiplostim, which is a subcutaneous injection taken once weekly. And we have the new one, avatrombopag, which is a small molecule like eltrombopag, again oral, taken once daily. They have different licenses, and you'll have to learn or work out what the license is for your country. But they improve the quality of life. They definitely do. And that's because the platelets predictably rise, and any bleeding the patient has will get better. If they have fatigue, it usually gets better. They just regain normal life. They can go to work, they can go to school, they can go to the gym. They just return to normality. Those patients who are on background medication, like maybe a small dose of immune suppressant or maybe a small dose of steroid, they can usually reduce those or stop the other medication. The infection risk on a TPO is 0, because TPO receptor agonists do not suppress the immune system, and the responses are lasting. I'll just go through briefly some of the data for the 3 TPO receptor agonists. For eltrombopag from Novartis, the 2 big studies, RAISE was a 6-month randomized double-blind placebo-controlled study, which was pivotal in getting the approval, and then EXTEND is the open-label extension study with no placebo. This is from the 6-month study. The green circles are drug and the pink squares are placebo. The drug clearly works. They reach the target count of 50,000 platelets or higher for the 6 months, and then the drug is stopped, and then the platelet counts drop back to baseline. Bleeding, again, green circles for drug and pink squares for placebo. The bleeding gets less for those on drug compared to placebo, but it returns to baseline when the drug is stopped. You'll see on the right, post-treatment. In terms of discontinuing or stopping background medication, 60% for patients on drug were able to stop other medications, but only 32% for the placebo group, which is good. We want people off immune suppression. I'm not going to go through this table. There was no difference in side effects between placebo and drug. For long-term safety, the open label extension study has been running for almost 10 years. It's called Extend. And these are just the plots here and you can see it going out from week 0 and it goes up to week 457, and it even goes longer now. The drug works, it keeps working. And in terms of safety, there are no new safety signals after 10 years continuous use of the TPO receptor agonists, which is very reassuring. Now, this is romiplostim, the once weekly injection. And there are two graphs. The top graph are the splenectomized patients, and they're much more difficult to treat. It shows non-splenectomized patients, and they're the much easier to treat group. But both groups respond beautifully. The squares, the black squares or the gray squares, are those on drug, and the triangles are placebo. Placebo never reaches 50,000 or more, but those on drug reach the 50,000 target. It may take 1 week longer in the splenectomized group, but they both respond. Side effects are very much like L-trombopag. Again, no difference between placebo and drug, which is exactly what we want to see. And then we have this new molecule, which has just been launched. And this is called avatrombopag, and it's a small molecule. It's larger than L-trombopag. It has 6 rings. L-trombopag has 4. It binds to the same site as L-trombopag, and you see there I put a blue shape around the binding site. The transmembrane portion of the TPO receptor is where L-trombopag binds, and avatrombopag binds to the same site. Like L-trombopag, it works in humans and chimpanzees. The difference between avatrombopag and L-trombopag is, well, one difference is that you do not have to reduce the dose in East Asians. There's no difference in their metabolism, and the pharmacokinetic variability gets less with avatrombopag if you take the drug with food. L-trombopag, you have to avoid food or certain foodstuffs. Avatrombopag works better if you take it with food. I'm not going to go through all their studies. They did a phase 2 study, which was dose finding. And then they did a randomized study like the RAISE study and like the romiplostim study, a 6-month double-blind study. And this is the structure of their study. They did a titration period to get the dose of avatrombopag right. Then they did a period where they reduced the background medication in the middle, 12 weeks, and then maintenance for 8 weeks. Now, they were looking at, the primary endpoint was the cumulative number of weeks with a platelet response, and a platelet response was 50,000 or more. And here we have avatrombopag in the orange column here, and 0 for placebo. So the drug works, placebo does not, 12.4 weeks. In terms of durability, 34-35% for avatrombopag, nothing for placebo. I don't want to go through all the side effects. I just want you to look at the bottom right of this table. ALT, AST, gamma GT, no change, no change. It does not affect the liver function at all. This is their equivalent to the Extend study, which is their open label study. Again, for safety, it doesn't go, obviously, it's not running as long as Extend. It only goes out to 74 weeks so far, but no new safety signals, which is good. So these drugs overall, they work incredibly well. They have an efficacy of at least 80%, if not 90%. So that means when you see a patient and they say, will this drug work? You can say almost categorically, yes, this drug will work. If you compare that with the old drugs, you cannot say that. They're very well tolerated. The platelet counts rise beautifully, bleeding is diminished, fatigue goes away, and the quality of life is good. But the strange thing is some patients on a TPO receptor agonist can be weaned off maybe after 6 months, and they have a sustained response off treatment. And looking at the numbers for L-trombopag and romiplostim, is around 1/3 of patients after a while can expect to taper and then stop the TPO receptor agonist and be on no treatment with a very safe count, which is amazing. It's remarkable. It was not seen in the trials, but it's because we taper. The clue is in the tapering. These drugs cannot be stopped suddenly, because if you stop this drug abruptly, the platelet count will simply crash again back to baseline. So comparing now immune suppression, the old treatment on the left, with the newer treatments, TPOs on the right, immune suppressants. There's very little evidence base that they work. They are slow drugs. They predispose patients to infection, some of whom may die. They're teratogenic, so they're not safe in pregnancy, and they have very variable efficacy, and they're not advisable during a pandemic. In fact, they're not advisable anyway, but especially during a pandemic. The TPO receptor agonists, on the other hand, have a very strong evidence base. They've been through randomized, double-blind, placebo-controlled studies. They're fully approved for ITP. The drugs on the left are not. The TPOs are approved, and there's no immunosuppression, and they have this high efficacy that I've shown you, and they are preferable during a pandemic. So after failure of initial therapy, what is our plan of action? Well, does the patient need treatment? Maybe not. Maybe you can watch. Whatever you do, the patient nowadays has to be central to your discussion. This is very clear that patients want to be involved in decision making. And we built this into the consensus, and the American guidelines also made this very patient-centric. No longer does the doctor dictate, the patient has to agree, and together the doctor and the patient decide on what the plan of action is and what the treatment will be. You have to discuss quality of life with the patient, the risks of the medicine or the risks of not giving the medicine, the toxicities of any therapy you wish to use, the infection risks and other factors. They want something that's well tolerated and is easy to take. So this takes us back to this group of drugs. They're well tolerated, they're easy to administer, they're associated with a good quality of life, they have high efficacy. So this was our strategy. I'm almost finished now, but this was our strategy before the pandemic. We would give initially steroids, sometimes IVIG as well. If that did not work or they relapsed, we would then use rituximab, mycophenolate. We like those drugs. And then if those failed, we would then look towards using a TPO receptor agonist. But since the pandemic, we've changed. We use steroids and IVIG, but then we go straight to a TPO receptor agonist. In fact, we have approval in England and Wales to use TPO receptor agonists as first-line therapies because of the pandemic. And so because of this, we very seldom use rituximab now. I just can't remember when we last gave anyone rituximab. Mycophenolate, we never start people on mycophenolate now either. So our treatment has really changed a lot, with the TPOs becoming very early drugs for us. So I hope I've shown you there have been big changes in management over the last 10 years. The patient is very much involved in the discussion. We should be aiming for safety and for quality of life. We're not trying to get platelets of 100 or 150,000. We want to keep them safe. without causing any harm to the patient. The new drugs, eltrombopag, romiplostim, have certainly changed our management style dramatically, and I don't think we will ever go back to the old style of management. The reason is these drugs are so good at elevating platelets without using any form of immune suppression. And for that reason, I would say that the TPO receptor agonists should certainly be used at the moment in the pandemic, and they should be used early. Try to avoid immune suppression. So with that, I will end, and I will stop sharing my screen, and I thank you for your attention. Thank you.